I'm Chris Henshaw. I'm the Associate Dean for the Undergraduate Nursing Program, and you're all here today to hear about our students who have been to Vietnam. This is the 6th class of students who've been to Vietnam. This is a program that we do in conjunction with an organization called MEDRICS, which is a nonprofit organization that works in Southeast Asia. They do safe water development, medical education, provide funding for heart transplants or for patients who need heart surgery, all kinds of heart surgery. And they also take 10 of our nursing students every year to Vietnam, where they study pediatric and community health nursing. They travel with Professor Barbara Jabish, who will speak to you in just a minute, and the executive director of MEDRICS, who is Laurel Catherman in the back, and her husband Bob, who's the president of MEDRICS. So I'm going to turn it over to Barbara. She'll introduce the students, and they'll let you know about their experiences in Vietnam the last couple of months.
Thank you all for coming. I just really appreciate this chance to be able to talk with you and to have the students tell you about the trip. I am just so humbled and thankful that I am the faculty person that has been able to go on this trip for 4 years. This was my 4th year, and it has just been a wonderful, wonderful group of students to be a part of the team with. They have come together, they have worked so hard to complete their goals, and they just really were gracious and wonderful to each other, really building each other up when people were sick or when people were having a hard time. And so it was just a really fun time to be together, and it's just such a privilege. They're going to introduce themselves to you as they give the talk, and so I'm going to let them go. Thank you.
All right, well, thank you again all for coming, and we're really excited to share with you about our experiences. My name is Emily, and that's a picture of me and 2 of the Vietnamese nursing students that we worked with. So before we left, we wrote a mission statement as a team, and it says, "We seek to reflect Christ as we learn with integrity in a cross-cultural context by strengthening relationships and demonstrating compassion while caring for the Vietnamese people." So that was really something that we tried to live out each day that we were in Vietnam. And we had 2 main goals before we left, and that was to increase our knowledge about cultural, ethical, and spiritual beliefs specifically related to nursing practice, and also to increase our critical thinking ability through use of the nursing process when caring for pediatric and adult patients, as well as family members in hospitals, clinics, and community settings. And as Ms. Henshaw said, we worked with MEDRICS. This was the 6th year that a team from SPU has gone, and they have long-standing relationships with the people of Vietnam. We had Mrs. Ha with us, who lives in Vietnam, and she is the program director for MEDRICS. And we also had Miss Lee, who was our translator.
All right, my name is Chelsea Van Dalen, and I'm going to be talking just a little bit about our experience with culture while we're in Vietnam. All right, first and foremost, the food while we were over there was delicious. I think it was a favorite part for all of us. I can speak for us. Central Vietnam, where we were at, was known for the smaller, spicy side dishes, and so we got to try different foods in the restaurants. Mostly we ate in the restaurants in the city, and then when we were in the villages, we got to eat at houses and see their different food and see the foods that they served us. One of the spicy ones was like a bamboo and chili pepper sauce, and so that was common for a lot of fish oil. A lot of the Vietnamese people, their staple foods include rice and fresh vegetables. There was a lot of fruits. For the meat, there's a lot of chicken and pork and seafood. We got to try a lot of squid and cuttlefish while we were over there. And a lot of the fruits include, there's mangoes and dragon fruit and passion fruit, mother's milk. So the Vietnamese students really introduced us to a lot and allowed us to try some. There's also a lot of herbs that are used in cooking food, and some mentioned up there. But yeah. And then while we were over there, we got to see some of the religions that were practiced. Primarily it's Buddhism over in Vietnam, and then there's a lot of traditional folk beliefs. while we were in the houses, we got to see a lot, or while we were walking, we got to see a lot of spirit houses. It's pictured in front of the tree. A lot of them would be outside stores or businesses, so along the streets they would be posted. And then we also got to see inside people's homes when we did home visits, a lot of spirit worship and like ancestor altars that were set up. And so we witnessed a couple different times while we were there. At the beginning or the middle of the month, they have larger celebrations where they let birds and they burn paper money as gifts and offerings for the ancestors. And then regarding the traditional folk beliefs, we got introduced to a lot of traditional medicine while we were there. Some of the clinics had herb gardens that were used, and there was usually doctors set aside for traditional medicine. And then also while we were in Vietnam, we celebrated Women's Day, which is celebrated on March 8th. It's an international holiday to celebrate women. We found out when researching the history that it was actually started in the US as a day to celebrate or for men to show their appreciation for women in their lives. It's a combination of Valentine's Day and Mother's Day. Unfortunately, the US isn't as continuing with it. But while we were over there, it was a big deal to the women, and they greeted everybody, shaking hands and saying Happy Women's Day. We got to talk. I know me and Michael went to this market on Women's Day, and we got to talk to women and just interview them and see what they do or how they celebrate Women's Day. And a lot of them receive flowers and letters from their husbands or family members, and their husbands often cook for them, which I think is a great treat. And then it's pictured here, a lot of women came to the clinics on Women's Day in order to receive their blood pressure, so that they got to take a lot of extra women's vitals and just get an opportunity to talk with them. And then we were also able to give soap to a lot of the women as a gift of appreciation and to celebrate them so that they could clean themselves. And we gave some to the clinics to give to the women if we weren't able to see them directly that day. So it was really neat to see.
And a funny story, when we were in the villages and going and interviewing people, it was me, Chelsea, and a couple Vietnamese students. And Chelsea was the only one to get a flower from just some random guy in the street. Out of the 5 other students, female students that were there, Chelsea was the only one.
Alright, hi, my name is Jocelyn, and I'm going to talk about water resources. In Vietnam, there is poor water quality due to the rapid urbanization and industrialization. There is also a lack of garbage control, which causes water pollution, and thus the main water treatment in Vietnam is by boiling the water. And we worked with Robert Catherman, the president of Medrix, in identifying the water sources in the Phong Dien villages. And most of the villages had piped water systems. Some had rain collection tanks, others had wells, and they all use bottled water, which is bad for the environment because there's no recycling system. Robert also designed a UV filter system that changed the structure of bacteria in the water so that it cannot replicate, and this helped reduce the infection-based illnesses and mortality rates of children under 5 in Vietnam. Overall, it was a great learning experience, seeing how the water sanitation affects health.
My name's Spencer, and I'm going to share with you about the nursing theory that we chose to be the foundation for our pediatric and community health clinicals in Vietnam. So we chose Leininger's theory of cultural care. It's pictured right here. Basically, this is the sunrise model, and what it pictures is culturally congruent care, where healthcare is delivered in a manner that's fitting for the cultures of the patients receiving the healthcare. I had an opportunity to practice this in Phong My on a home visit. I was talking with a man who is a lifetime smoker. He smokes cigarettes. So his culture would be that smoking cigarettes is what he's always done. And so coming up with the solution of cold turkey, let's not smoke cigarettes, wasn't the most effective way to deliver care to this man. And so I was able to talk with him and look at his ashtray and see what cigarettes were in there turns out they were unfiltered cigarettes. So the first step was, let's do filtered cigarettes. And then instead of 2 packs a day, maybe we'll bump it down to 1.5 packs or 1 pack. And just gradually make subtle changes within the context of this man's culture. And I think that's kind of an example that would be befitting for a lot of the teaching and a lot of the education that we were able to do in Vietnam, in both the pediatric hospital and also in community health, where we were in clinics and also in people's homes. It's about figuring out where people are at and giving them the health care that gets them from where they're at to where they could be or should be in a context that's congruent with their culture.
Hi, my name is Maggie, and I'm going to be sharing with you about our rotation in the hospital. But first, just a little overview. We worked at Hawaii Central Hospital for our pediatric rotation, and that was 2 weeks. And then the next 2 weeks, we worked in Phang Dien district as part of our community health rotation. So you can see Hue is in central Vietnam, and then the Phang Dien district is about 80 kilometers north. So Hue City, it's located on the Perfume River, or the Sung Hung River. And we were there during the dry season. Very nice, we didn't get rained on very much. So while we were at the hospital, we partnered with the doctors, and so 2 of us would be paired up with one of the doctors on a specialty unit, and they were amazing teachers. They meticulously went through the pathophysiology of whatever specialty we were working with, and then worked with us a lot on assessment, and there they do a lot of palpation and percussion, which we don't see a lot here, but we got very good at that. And something different, because they don't have as much resources as we do. They don't just order a bunch of lab or blood cultures or x-rays, and so a lot of it is just through their assessment and the history that they can obtain from working with their clients. So we worked on the gastrointestinal unit, ICU, nephrology, respiratory, and oncology. And so the main diagnoses that we saw were upper respiratory tract infections, pneumonia, diarrhea, nephrotic syndrome, nephritis, and leukemia. And I think something that I took away from this was that a lot of times when any situation that we go into, I think we feel like we can come and save people, or that we're gonna come and fix things based on what we think needs to happen. And it was really humbling to see how the doctors were able to work with these people in culturally competent ways in ways that I wouldn't have thought. And just to do it so well, and not necessarily how we would do it in the US, but for the people, that was the best way that they could give care. That was really cool to see.
Hi, I'm Courtney. I'd like to share with you about a case study that we saw in the hospital. It was a patient in the ICU. He is an 18-month-old male. He came to a district hospital 500 kilometers north of Hue, originally because of his lip, and it just never really healed up. And so he got sicker and he came to the Hue hospital. A large problem that he had was malnutrition. He was 6.8 kilograms, which is roughly 14 pounds. Normally, a child that is 18 months old weighs 24 pounds. So he was severely malnourished, and in his month-long hospital stay, he'd actually lost 1.5 kilograms. And to make matters worse, he had a gastrointestinal bleed that they found out when he was vomiting blood. And so then he was on an MPO status, which means he's not able to take anything by mouth, so he wasn't able to continue eating. He had a medical diagnosis of macrophage activation syndrome, which is a complication of an infection. And it comes from the overstimulation of your immune system, but the overstimulation is actually really ineffective, and it causes a decrease in your cells and your red blood cells, and you have anemia and just really complicated his malnutrition. So instead of writing medical diagnoses, as nurses we write nursing diagnoses, which kind of address more social or problems that can be treated without medication. And so we wrote imbalanced nutrition, less than body requirements, related to insufficient parental knowledge about adequate nutrition for this child. Also, the parents had inadequate resources for providing formula or for the mother to have enough food so that her breast milk is sufficient. They also complicated by his lip injury and his MPO status. And his imbalanced nutrition was evidenced by his low body weight of 6.8 kilograms. The hospital treated his macrophage activation syndrome with antibodies called immunoglobulins, which help target the infection. And then they also gave him omeprazole to lower his gastric acid, which helps with to stop his GI bleed. And then we focused on addressing his malnutrition and talking with the physicians about getting his calorie intake up after his GI bleed had stopped. Something that we weren't able to do because he was in the ICU is talk with his parents, because in the ICU the parents aren't allowed to be in there very often. And so unfortunately we weren't able to talk with them, but we also collaborated with the physicians, and they would instruct the parents about ways to increase his nutrition when he goes home.
My name is Michael, and I'm going to talk about the community aspect of what we were doing. As Maggie said, we were able to go into the villages of Phong Dien for 2 weeks. We spent the 2 weeks rotating around at different clinics. We went to Phong Mi, Phong Hien, Phong Sun, and Phong Xuan. I know we all had a great time. We got to see a lot of different kind of cases, and we also got to bond a lot with each other and a lot with Vietnamese nursing students whom we partnered with. A lot of what we were doing there focused more on assessment and inflow of patients. So our typical day would normally start around 7:30, 8 o'clock, and that's usually when patients would start coming in. We would do a full body assessment, ask them why they're there, what kind of symptoms they have, and then after we would do an assessment, we would come up with a mock diagnosis, and then they would go over to the doctor or whoever was there, and they would get medications, and then they would leave. So the morning was just assessments and patient inflow, and then the afternoons would be us going to schools and doing oral education and hand hygiene, and then we would also do home visits, which we'll also talk about later. A lot of the stuff that we saw was respiratory issues. We saw a lot of hypertension with the elderly clients, just because they love their sea salt and they love their fish sauce, which has a lot of salt in it. And we saw a lot of arthritis, and a lot of these diagnoses would change over the course of the year depending on what season it was. And then also during the 2 weeks we were able to spend 2 days at the district hospital. We spent it going through infectious diseases, labor and delivery. Some had an opportunity to go to the ER, and we saw a patient who had, I think, a full body electrical burn. That was really interesting to see. We have pictures. It was a little difficult a couple of those days because I think two out of the 4 clinics we went to were under construction. And so it was interesting to see how the staff would change the environment to try and accommodate to the clients that were coming in. It was just difficult sometimes because one of the clinics had the assessment room upstairs, and the stairs were under construction, and so yeah, it was kind of hard. So one of the days I got the privilege of helping just elderly patients up and down stairs, which I don't know, it was pretty humbling. Just you would see these patients coming who were bent over at like 90-degree angles, and they just want to get upstairs, and so you would help them up, and then with all their strength, they would just give you a huge hug, and with little English they would have to say thank you. So, as I said, we got to partner with Vietnamese nursing students who have their college in Hue. What typically we would do is we would have 2 or 3 of us, and then we would partner with 2 or 3 of them, and they would act as our translators with the patients. And it was great to see them interacting with patients because they were so warm and just, they knew how to communicate with the people there, and it was really cool to see.
My name is Leah, and that is a picture of me with the patient that Courtney talked about in the ICU, and he had a warm spot in my heart. He was so cute, and as you can see, he made eye contact with us, and at one point he was saying, May, May, and I asked the nurse, I was like, what does that mean? And he was calling for his mother, and so it was just great to see and be able to interact with the children, because even though in the ICU we weren't allowed to do a lot of the procedural type stuff, we got to pay attention to the patients and give them the love that they might be missing out on because their parents are there. Another thing in this picture, you can see the little restraints on the baby's arm, and that's something different in the hospitals there. The children are restrained in the beds, just in ICU, and it's with cloths, and they're really good about having them loosely tied, but it's just because they don't have enough patient-staff ratio to manage that, so it's to make sure they don't pull out lines or mess up with the equipment. So that's that picture. I'm going to talk to you about the home visits, and the home visits were probably one of my favorite aspects of the trip because it was a chance for us to interact with the patients in their home environment, and we were able to assess not only their health, but also their living conditions. So as Jocelyn talked about the water, one of our goals was to see where their water resources were coming from, whether it was a well that the community shared, or if some people had piped systems or boiling water. And so that was a chance for us to see that. And education was our main focus, and a lot of times we didn't know what we were going to run into in a home visit because it was like, okay, we're going to take you to 3 houses, and so we were prepared to talk about many different topics about mothers who had just given birth, so nutrition and postpartum care, to garbage and waste management and all sorts of things, nutrition. And so this one specific house visit was for a primary school teacher, and there was the group of us, the nursing students, the Vietnamese nursing students, and 2 of the SPU nursing students, and we were with 2 faculty members. So we had a lot of people to help translate, and we were escorted by this mother from the main road back into her house, and so this was kind of the first opportunity I had to go off the main streets and see a house that was more back in the community. And there's a picture of the housing, and it was what we would consider like subsidized housing, and it was for teachers in the area, and it was little 1-room houses, and they were so welcoming and had seats for all of us. And in that picture, we walked in, and right away we knew what we were going to be teaching on. This baby was extremely overweight and a health risk for the baby, for diabetes, and just a lot of other health issues. So we were able to collaborate, and we assessed with the mother by talking about what kind of things she feeds the baby when she's home, and all of that. The mother works during the day, so the mother-in-law lives with her and feeds the baby. And the dad is an artist, so up way in the north, so he travels all week and is only home one day on the weekends. And so the mother would breastfeed the baby before she would go to work, but then during the day, the grandmother would feed the baby sugared rice milk. And so that was the cue that we needed to be teaching about the right formula, because that excessive intake, and it was probably viewed as sort of a nurturing thing to keep the baby calm and happy. And also culturally, it's good to have a chubby baby because it shows wealth. And so we knew that we needed to address the formula, but then also that it was unhealthy for the baby, and risks that it could cause. And so the mother was very open to what we suggested, and she showed us her formula, and it took a while with the translation to figure out what ingredients were in the formula and where she bought it and how far she had to go to get it. And so with living in this little housing area, there were lots of resources for her with all of her neighbors so close by, and everyone was so welcoming. And so from another resident, we found formula that was the correct formula, Similac, and so it had what she needed. And so we were able to show her, this is the formula that you need to buy, and are you able to get this at the market? And she said yes. And so through that, we knew that she had the resources to buy the formula, and it was close enough that she could get it. And so yeah, this is a 5-month-old baby, and as you can see, it probably weighs close to what a 2-year-old would weigh. So yeah, and then we talked to the grandmother and said, we know you're so proud to have this chubby baby, and she laughed and smiled, and she was so happy. But we explained to her, you are a great grandmother, but this is something you need to make sure you're feeding the baby, the appropriate time intervals. So every 3 to 4 hours, and then also to make sure it is the right formula, because baby has enough body fat, it's not starving. So yeah, it was a great teaching opportunity. And then for our nursing diagnosis for this patient was imbalanced nutrition, more than body requirements, related to excessive intake of sugar rice milk, as evidenced by the excessive body fat. And then other sorts of teaching opportunities we had, we saw a lot of mothers who had just given birth, so postpartum patients, and in their culture, they have traditions and customs about bathing and what sorts of foods that they eat. And so the mother wasn't always eating the right foods to stay healthy and have good breast milk. And so we taught about breastfeeding and what sort of nutrition she should have for herself. And we saw a case with twins, and that was an opportunity for us to do some education about that sort of thing. So yeah, I really liked the home visits, just interacting with the patients and doing that part of our study.
I'm Bethany, and I'm going to talk a little bit about, we were in the market, I had to hold a baby duck. I'm going to talk a little bit about something that we would have typically, well, this actually was very not typical, that we saw in the community. It was kind of really interesting because we got to be in these villages where you really never knew what was going to come through the door. And so we saw all kinds of things that we probably wouldn't have ever had a chance, or very rarely had a chance to see here in the United States. So this was at Feng's Sun Clinic, one of the clinics Michael was talking about. And this woman came in, and initially when I saw her, I thought, she has a chemical burn. Like, it looked like from head to toe that she had been burned and had scarred a little bit all over her body. And as I started talking to her, and the nursing students were gracious and started translating and trying to communicate with her what had happened and the history behind what was going on with her, she told me that this appeared 7 years ago, that she was never burned, it just appeared. I'll show you pictures. I will warn you, they're graphic, so if you're queasy, or just fair warning. You can go ahead and flip it. And so she had this staph infection or some sort of infection all over her body that she's had for 7 years. She explained to us that she has gotten IV treatment at the district hospital for a week, and then it'll go away for 3 days. And so she's lived with this for 7 years. She has 6 children. The youngest is 4. So she had a baby with this infection. Her husband came with her as well, and he was seemed to be very supportive and had brought her to the clinic. So she really tugged at our heart, and it's really hard to see this because she probably has had a lot of social isolation and social stigma around her condition. She's not able to cook for her family because of the infection it could cause to her children. Her children are teased because of her mother. Her grandmother lives with her, the children's grandmother, and does all of the caretaking for the children. And her husband is a farmer. So they were kind of strapped as far as a lot of what they could do. So we were able to, with the help of Medrix, and Laurel was gracious to connect them with a doctor in Way Central, which is the hospital we did our pediatric rotation at, to see if we could get her some long-term IV therapy to actually get rid of this infection instead of just doing it for a week and then sending her home. We found out she hadn't had a new sleeping mat in longer than she can remember. And in Vietnam, they don't use blankets or anything like that. They use it's like a wooden or a metal bed, and then they just put like a straw sleeping mat over top of it. And that's how they will take their sleeping mat to the hospital with them, and they lay their sleeping mat out. And so we were able to provide some resources so that she could get a new sleeping mat. And then also, in the hospital, you have to provide you or your family provide your food and your basic necessities, your care. So she was looking at having to be able to provide food for 8 or 9 months, hopefully 6 months at least, in the central hospital for herself, which was going to be a burden. So hopefully with the things we were able to connect her with, she'll be able to get some help. But it was just something you really had never seen. And she was so grateful. It's very moving to see.
My name is Bethany, also, or Bethany Krug, or BK. I get the privilege to talk to you about one of the highlights of our trip was getting to teach in the schools. So in the afternoon, as Michael said, we got to teach either in the preschools or the primary schools. So with the preschools, we had 3 and 4-year-olds. We would only teach them about hand washing and oral care, and we really had to change our program to make sure it could reach them and so that they could understand. So we had a lot of fun with those kids. In the primary schools, we taught them more about oral and hand washing, and then we also taught waste management and about worms. And we tried to empower these kids to be like, go home and go teach your family and your friends and go be teachers. So it was a lot of fun. So with the hand washing, so what we would do is we brought our own supplies, and we would work very closely with our Vietnam peers. They were very gracious and worked with us. We had flip charts, and so we would stand up in the front and say something in English, and then they would translate for us. After we went through our flip charts, we would demonstrate to the children. So with hand washing, we would go up front and show them how to properly wash your hands, and then we would sing happy birthday to make sure that it was long enough. So we had to be happy and sing very loud for these kids, which they loved. So it was really a joy to do that. After we demonstrated to the children, we'd have them come up and demonstrate to us to make sure they were understanding what we were teaching about, and just to reinforce that and then help them to go home and teach this to their families. And then with oral care, after we were able to teach, with the generous donations that we received from a dentist, Dr. Andrews, he gave us 500 toothbrushes and toothpaste. So after our teaching, we were able to give each of the kids this gift, and they were just so excited. The first school I went to, they were ripping those things open so fast. So we would teach them how to brush their teeth, and we had some of the kids then teach us or make sure that they knew how to brush their teeth, where to brush their teeth, how many times a day. So we just had a lot of joy with that, and we also just with that time in the schools, they would ask us then to sing for them. So we would teach, and then they were ready for us to sing. So we had to do the Itsy Bitsy Spider, we did so it was a lot of joy, and just to be with the kids and interact with them, and just to be able to bring this gift of the toothbrushes and toothpicks.
And so we would like to say thank you to all of you for coming. We've shared a lot about the trip, and so for the upcoming students, if you guys have questions, parents and mom, any questions. Oh, and we'd also like to thank Bob and Laurel Catherman for their partnership with SB.
Barbara and Laurel and Robert.
And also the nursing professors that altered schedules and
Really hard to get us out
crazy
here.
class hours to get us on the plane. Eileen, Chris, Kathy Simmons, Kathy Stetz. I assume all the professors talked, so everyone else that was included in those discussions.
Thank you so much.
Thanks for coming. If you have questions, feel free to ask. We'll stay around for a while. Dr. Henshaw.
I have a question. The woman who had the staph infection, so she'd had that for 7 years. Was there a particular reason that she came to the clinic at that time, or was she just looking still for treatment in general?
Laurel, you might know.
I remember. She was going to the clinic to get medication that she had been receiving just to kind of help with the pain that she had had. And it was like a topical medicine. And she had gone to the first clinic and they didn't have the specific medicine that she needed. And so that was, my clinic was the person that saw her next. And at the end of the day, I was like, you will not believe this patient that we saw today, blah, blah, blah. And they were like, oh, she was at our clinic first. And so she was able to get the medicine that she had been receiving at the clinic that we were working at. But it wasn't treating the actual cause. It was just a comfort measure. So
They kept wanting to refer her to a dermatologist. There was a little discrepancy as to whether she needed to see someone from like infectious disease or if she needed to see dermatology, or so there was kind of a little bit of each.
but money, again, was the big issue because she couldn't afford to leave her home and family and support herself in the hospital without food and extra money. So that's how we were able to help her by giving her what would be so small here can go so far there. And so that's what the donation was able to help her with.
And if I can add something to that, we think that probably the original problem was a chemical burn from the pesticides that they use in the field. She and her husband are farmers. And then on top of that, she probably got the staph, which just continues to reoccur. So we actually have some doctors from the Seattle area who are going to be away in about a month. And we're scheduled to have her meet with them also.
As a community of people, what is their greatest need there, where you were?
In Phang Dien or in Hue?
Well, both. Maybe it's different.
Phang Dien, I personally, I mean, you guys might have different answers. I personally think it's just availability of resources. When you don't have resources, there's not a whole lot you can do outside of what you're doing. They go to work every day, they come home. They go to work every day, they come home. That's just the cycle that they're in. And everything that we dealt with, everything that we saw was attributed to either the lack of resources or the inability to get to the central hospital or the inability to get the necessary care that they needed. So there was it's multifaceted, but
I think where we were able to help with, I think a big thing was just basic education on health and hygiene. So by something so simple that we would think like washing hands or good nutrition, we could teach them that, where they could teach their other community members, because they all interrelate so closely with each other. And so the small education that we gave them helped with those resources that they might not be able to go get in the city or other places. Yeah.
I'm wondering, the case with the grandma that was feeding the baby,
Yeah.
her grandchild, how did you handle being young and American and honoring her intentions in that?
Yeah, that's where it is so helpful to have the Vietnamese students, and we also had a Vietnamese doctor with us that day. And so as we're figuring out what we're going to teach and we teach together, they provide us with the cultural insight or remind us about things like they might have to drive 30 minutes or walk 2 miles to go get this formula. So they remind us of those things that we don't think about. And help us to be culturally aware of what sort of education we're giving them. And that's why we try to first start by praising them and telling them, thank you for having us here, your house is beautiful, because with the small one-room house they had, it was clean, very clean, and they had their little kitchen in the back, and everything was really well organized, and the baby had a cradle. So we praised them first with what they did have and what they were doing well. And then from there, we would do the education part, and then end again by thanking them and telling them all those great things that they were doing.
Several of you mentioned common upper respiratory conditions. What do you suppose contributes to that? And can you talk about that?
I believe it was weather at the time. In the hospitals, also with the babies, we saw the mothers feed the babies lying down with the young birth, and so that was a big struggle for me, like just to see babies choking and the mothers freak out and lay their child down, and we would come and be like, no, let's do this. That's probably some of the reasons.
Lack of education. Yeah, lack of education about hygiene. I think one time in the hospital, I saw mothers, they were just trying to help each other, and one mother didn't have the piece that she needed to administer a nebulizer treatment to the child for the lung condition, and so she graciously gave her child's to another child, not realizing that that could spread infection. And so, again, we just thanked her for being so kind, but also that can spread infection.
Also, just pollution agitates it, and they are inhaling a lot of smoke with cooking inside the home. So.
Open fire cooking, not stoves. Yeah.
Any more questions? Michelle.
What do you guys feel like you learned from this specific experience that is going to affect your future nursing practice?
Good question.
I think there's a lot to be learned in just patient interaction. Really kind of having to realize that, yes, we've all been through school and we have the education that's going to help people out. But the way that you deliver that largely impacts the way it's going to be received and actually acted out. And so delivering health education or even just nursing care in a way that's, according to Leninger, culturally congruent, and also just really respectful and affirms the strengths of the people receiving the teaching. I think we can all agree will largely impact the way that we will deliver care, and it's always something to be kind of mindful of as we're all learning new things and as we're taking on different jobs and graduating and all that.
For me, I think it's going off of that, but how to care for patients, but as well as their families. I mean, while we were there, families were everywhere. I mean, when the Hue Central Hospital, it would be the little kid sitting on the bed, and then it would be a mom, it would be an aunt, and there would be dad coming and visiting, and then so it just learning how to incorporate teaching not only to just centralize on the patient, but also including the families on education and just keeping them informed.
I think we're definitely all more prepared on assessments, especially on the nephrology floor. We spent a lot of time with Dr. Tan, and he was very systematic. And we would spend 45 minutes or an hour and just go through every system and do the floor, like percussion, auscultation, inspection.
Yeah, the patients were very kind. Very kind. They just sat and listened, and then we would do one system and talk about it, and then they'd let us go on next. They were very generous to let us learn in an environment like that.
Super patient.
Yeah.
So I think we saw another type of, like, we learned the head to toe assessment, and then here it's like body system by body system. And he's very adamant about that. So just another, like, opening of your minds and seeing how there's just another way that there's so many different ways to do one thing, and to assess and really learn a history and see where they're coming from. So.
Free to go. Yeah, thanks for coming.